Welcome to EasyMed. Today we will be discussing about hepatitis B. Hepatitis B, as of today's clinical practice concerned, is a real problem. In the OPDs and in the outpatient departments, you will see a lot of patients with hepatitis B. Many of them are cases with complications, and many cases you will find, like in my personal experience, I have seen cases of patients having hepatitis B, HBs antigen, HBs AG load more than 12,000 units, but there is no liver complications. All the liver parameters in the LFT are normal. So such cases you will also come across. So let us start discussing about hepatitis B. Now, hepatitis B this is a DNA virus having partially double-stranded DNA, dsDNA, and the family is Hepadnaviridae. So to understand the clinical basis of this whole thing, hepatitis B, we will first discuss about the virus a little bit, then we will move to diagnosis, clinical situations, and then we will move to management. Okay, so this virus has a complete negative strand with polymerase enzyme, and incomplete positive strand with primer. Incomplete strand with primer. That is why, because of this typical structure, this is also called relaxed circular DNA. Relaxed circular DNA. Now, before moving into details of hepatitis B infection, let me give you a synopsis of how the liver problems, the pathology proceeds. See, so if there is acute hepatitis, 1 to 5%, around 1 to 5% will proceed to chronic hepatitis. And from chronic hepatitis, very less percent, around less than equals to 2% or more, will proceed to liver cirrhosis. And in liver cirrhosis, the manifestations, as manifestation of liver cirrhosis, you can see portal hypertension, you can see liver failure, and you can as well see hepatocellular carcinoma, HCC, hepatocellular carcinoma. Now, this chronic hepatitis can be caused by vertical transmission, that is from mother to fetus, and this acute hepatitis can be caused by percutaneous exposure. That can be like IV drug exposure, or it can be sexual route. The sexual route is like primary reasons of transmission of hepatitis B in most of the cases. Apart from that, this drug abuse, it is found in narcotic abusers, drug abusers, and in some cases also, if there is lack of sanitation in hospitals, such cross infection, patient to patient hepatitis infection can also occur. Now let's talk about HBV infection. Hepatitis B infection. So in hepatitis B infection, what you can primarily find is acute hepatitis, that is caused by percutaneous exposure, or sexual route, or it can be IV drug abuse. Now, it can be caused by vertical transmission, but vertical transmission, as I have already said, proceeds to chronic hepatitis, and chronic hepatitis can cause hepatocellular carcinoma. Let us discuss the virus, and so we will discuss the components of the viral gene, and these components are very important in diagnosis. So genetic material, there are 4 genes: the S gene, the C gene, P gene, and X gene. And the flow of this genetic scheme is from start to stop codon. Start codon, that is location of S gene is near the start codon, and location of X gene is near the stop codon. Now, what is this S gene? So basically, S gene codes for HBsAg, that is the surface antigen. Now this is used, this quantification of this HBsAg is used in diagnosis often. So this HBsAg is very important from clinical perspective. Then we have the C gene. The C gene is actually core protein of the virus, HBcAg. Now this HBcAg at times can be seen in blood. At times it can be seen in blood, but at times it can be intracellular and can't be detected. Now there is another portion of this C gene which is called the PREC-C gene, which codes for the envelope protein. Codes envelope protein, or HBeAg. This HBeAg also has clinical perspectives. Then P gene. P gene is basically, as you can guess from the name, this is the polymerase gene. And this codes for the reverse transcriptase enzyme. This codes for reverse transcriptase enzyme. And then there is the X gene, which codes for HBX antigen. And this role is unknown, yet to be discovered, unknown. Maybe you can take up this as your diploma thesis, or a very good topic for thesis and research, the role of HBX antigen, HBxAg. But it has been postulated that it might have some role in development of HCC, carcinogenesis. It might have some role in carcinogenesis, but it is not confirmed yet. Acute hepatitis. Now let's speak about acute hepatitis B infection. Acute So in case of acute HBV infection, what can be the mode of transmission? The mode of transmission. Percutaneous exposure. Now in this percutaneous exposure, the chance of HBV, hepatitis B, HBV being positive is 50%. In chance of HCV being positive is around 0.6 to 6%, and chance of HIV, this is just I am giving a synopsis, of being positive can be around like less than 0.5%. So the first thing, you have such a history of a patient, you should be suspecting and going for workup should be your HBV. You should never miss HBV. Along with HBV, you can go for testing HCV and HIV, but HBV you should never miss in clinical situations. Now in blood transfusion, blood transfusion, transmission of HBV through blood transfusion, it can be, but in practical scenario, this is very rare. Around 1 in 200,000 cases. But it can be seen in IV drug abusers. Acute HBV can be from sexual mode of transmission. And minimal chance can be transmission via breast milk. And there is no fecal-oral transmission in case of hepatitis B. No fecal-oral transmission. The incubation period of hepatitis B is around 60 days. Now let us discuss scenario in clinic. So in the clinic, the prodrome will be around 2 to 3 days. There will be fever, malaise, vomiting, and importantly jaundice. Do check the color of sclera if you suspect for HBV. So get to know first if there is jaundice. Now in clinics, HBS antigen, this excuse me, HBsAg, this is the first marker. This is the first marker to rise, and this marker is seen even before prodrome. Before prodrome, that is around within 1 month of exposure. Now HBeAg, this might be positive along with HBsAg. HBeAg, this is a point to remember. HBeAg is infectivity marker. Infectivity marker. If this is positive, that means infectivity is very high. And if this is negative, then infectivity is low. Then we have the anti-HBC, which is seen around 2 to 3 weeks after the usual rise of surface antigen. And initially anti-HBC IgM is positive. So in acute hepatitis B, presentation, how it will present? The presentation will be HBs antigen positive, HBe antigen plus minus positive or negative, and anti-HBC IgM definitely positive. What is the best marker for hepatitis B? This is anti-HBC IgM. Now this is also, so as I have discussed here, the rise of the positivity of anti-HBC is even before is just after 2 to 3 weeks of HBs antigen. So even in some cases when HBsAg is negative, you can find this as positive. The qualitative marker for hepatitis B infection is HBeAg. And the quantitative marker quantitative marker is HBV DNA. Now let us discuss what will be the fate of this acute hepatitis B infections. In acute hepatitis B infections, greater than around 95 to 99% of the patients will recover completely. 1 to 5% generally proceed to chronic hepatitis. The incubation period is around 8 weeks. And the symptoms might show up. Symptoms can show up around 8 to 16 weeks. The HBsAg can be used as screening test. Now let us discuss what in transplantation patients. In transplantation patients, the HBsAg and anti-HBC IgM what happens with them? If both are positive, then there is definitely chronic hepatitis. And if HBsAg is negative and anti-HBC IgM is positive, then this can be a remote infection. Or this can be S gene mutation. That is occult infection or vaccine exposure. Now let me come to a very not very important but not clinically very significant, as you don't find patients mostly, but there are cases. So we let us discuss what in pregnancy. In pregnancy there is a rule called 90-10 rule. So in 90-10 rule, you measure the HBeAg, you measure them. If this is positive, then there is 90% transmission risk. That is vertical transmission. And if this is negative, then there is 10% transmission risk. Now, what should we do in case of these pregnancy cases? The management. First, we should go for checking up this 90-10. We check up this 90-10 status, and the preferable time to do is the third trimester. Now if there is mother to child infection, that is a mother with hepatitis B, she gives birth to a child, what should we do? So HBV mother gives birth to a child, what should we do in these cases? So we should give 0.5 ml HBIG soon after the birth, that is the immunoglobulin, hepatitis immunoglobulin, soon after the birth. First dose HBV vaccine we should administer to the child within 12 hours of birth, within 12 hours. And in around 28 to 32 weeks of gestation, if the mother's viral load is greater than 2000 international units per ml, then start managing the mother. Let us discuss the life cycle of HBV in brief. Life cycle. Now first, infective particles bind on the hepatocyte receptors, and infective particles bind on hepatocyte receptors, primarily on the sodium taurocolate co-transporter. Then there is excapsidation. Now the virus enters into hepatocyte nucleus. Now the relaxed circular DNA, that is the CCC DNA we call it, with the help of polymerase enzyme, integrate into the host chromosome DNA, and this can't be eradicated. We can't eradicate HBV forever. So CCC DNA, triple C DNA, that is the circular. This is. Let me write the full form. This is called covalent closed circular DNA. That is the relaxed circular DNA. Excuse me. Sorry for my misinterpretation. The relaxed circular DNA, actually, relaxed circular DNA. This forms, actually, just there is a changing in the structure. This forms the covalent closed circular DNA with the help of polymerase enzyme. Now this CCC DNA, this triple C DNA, they integrate into the host chromosomal DNA, integrate into host chromosomal DNA. That is why the HBV can't be eradicated. Now, if HBV can't be eradicated, what should we do with the patients? We just don't manage the patients, like we just do symptomatic therapy and we leave the virus alone to survive there? No, absolutely not. We should try to decrease the viral load. The objective of the treatment should be decreasing the viral load to less than 2000 international units per milliliter. Now, what happens next is the CCC DNA use host enzyme to form a pre-genomic or subgenomic mRNA. This thing they use host enzyme to form pre or subgenomic host pre or subgenomic mRNA. Now this mRNA moves to cytoplasm, and this translates itself and forms the surface protein. Now what we suspect is, what the current research suspect, that this protein translation, this is controlled by the HBx antigen. That is why few researchers suspect that this HBx antigen has a role to play in carcinogenesis. Apart from that, this mRNA converts to DNA also with the help of reverse transcriptase enzyme. From here, they convert to DNA by the help of reverse transcriptase enzyme. Now this reverse transcriptase enzyme has two components. The first component is RNA dependent DNA polymerase, and the second component is the DNA dependent DNA polymerase, The final step of infection, the life cycle, actually it's not infection but life cycle, is that is the complete virons are formed. After all of this process, complete virons are formed, and this is secreted out of the hepatocytes, secreted out of the hepatocytes. This is secreted out of the hepatocytes. Now let us come to the management of hepatitis B. First, we will discuss about the primary drugs which we use for management of hepatitis B. Then I will move to few peculiarities of treating different cases of hepatitis B. So, management. Drugs. Okay. Drugs. So there has been a long history of changing recommendations of drugs which are used for management of hepatitis B and all, starting from 1992, and the last recommendation coming out at 2016. And newer drugs are also under development. So hepatitis B is basically a whole arena of R&D, research and development. So I will not be surprised if any new recommendation comes up and the current regime of management is changed in a few upcoming years. Okay, so let us discuss. So if we frame like a timeline, in 1992, the recommendation was use of IFN alpha. Now IFN alpha has had its drawbacks. Now this can't be used if it can't be used. This is contraindicated if there was HBeAg negativity. This can't be used if there is cirrhosis. This can't be used if there was cirrhosis. Now this was also given subcutaneously, which is a challenge while treating patients with hepatitis B, because you have to give continuous therapy for long time, and the patient always have to come to you in your clinic for getting the doses of the drug. So that was not a comfortable thing, and it was found that there was no effect on young Asian population. And the problems which clinicians faced at that time with the use of IFN alpha was there were neuropsychiatric effects, of long use of this drug. And then there was irreversible toxicity, primarily causing autoimmune thyroiditis. And there was also a very dangerous side effect, which was dose dependent bone marrow suppression. Then around 1998, we started using lamivudine, but the thing was, there was seen YMDD mutation in after 3 to 4 years, and this became resistant. Around 2002, clinicians started using adifovir dipovoxil, tenofovir dipovoxil, which again had its shortcomings. Around 2005, Pegulated IFN alpha along with entecavir was being used, but this also had its problems. It was previously DOC, a drug of choice, but then there was development of resistance, and along with entecavir, tenofovir was also used. Tenofovir disoproxil was also used, and this caused this component specifically caused nephrotoxicity. And then around there were other recommendations, like in 2006 telbivudin was used. Telbivudin. Around 2008 only tenofovir disoproxil fumarate. And 2016 onwards we used tenofovir alafenamide. And until today we use tenofovir alafenamide. Action: assessment of use of this drug should be, that is, after using this therapy with tenofovir alafenamide, the HBV DNA load should come down to less than 2000 international units per milliliter, as I have already said. And so this is the aim of the treatment, the goal of the therapy in case of use of tenofovir alafenamide. Now let us come to peculiarities of treatment of hepatitis B. So what should be the management of acute hepatitis B? If there is acute HBV, the management of acute HBV should be like this. First, check for anti-HAV and anti-HEV IgM. Then if negative, check for anti-HBC IgM. First check anti-HAV and anti-HEV IgMs. If negative, check for anti-HBC IgM. Now in most of the cases, in 95 to 99% of the cases, you will find that the HBS antigen and anti-HBC IgM are positive. These are positive. So you confirm, then you confirm acute hepatitis B. So in acute hepatitis B, first treatment should be only supportive therapy. Only supportive therapy. Then do check for the INR value. If the INR value is greater than 1.5, then go for antivirals. go for antivirals. Now, what should be the management of chronic HBV? Chronic HBV. In management of chronic HBV, the HBs AG and anti-HBC IgG, IgM should be positive. This should be positive. You can go for a liver fibroscan for assessment of cirrhosis. Now, primarily, like personally, this is a recommendation. Personally, I think you can do an USG, and if there is cirrhosis, then you can go for fibroscan. Now, in many countries, these primary tests like ultrasonography and X-ray, these are all government insured. So what you can do in management is you can go for USG, because in clinical practice, I myself have seen a lot of patients who have hepatitis B for a long time with high HBV DNA load, but no change in liver structure, nothing clear. All the LFT parameters, everything are normal. But once you find in ultrasonography cirrhosis, and or you can go directly with fibroscan. Once you find cirrhosis, you go for fibroscan, go for assessment of the cirrhosis. Now, if there is no fibrosis, you will do management, start treatment only if ALT 2x of normal, and if there is fibrosis, if fibrosis is found, definitely you go for management. Now in and if you check for the INR, if it is greater than 1.5, no matter if there is cirrhosis or there is no cirrhosis, whatever it be, or if there you check for bilirubin, and if this is greater than 3 milligram per deciliter, definitely go for managing the patient. Now we come almost to conclusion of our topic. Just to add up, what can be the extrahepatic manifestations of hepatitis B infection? Arthritis, dermatitis, syndrome. There can be vasculitis, mostly polyarteritis nodosa, and there can be glomerular disease, mainly membranous. If there is any of these extrahepatic manifestations, do manage the patient. So with this, dear doctors, we come to conclusion of our topic, hepatitis B infection. Do share the video, like the video, and subscribe to the channel and press the bell icon. Thank you.